You're listening to the Good Question Podcast with Richard Jacobs. Our goal is to make each of our guests exclaim, that's a good question. I don't know the answer. Because when that happens, it means you, the listener, may be inspired to learn more beyond the interview and to ask great questions yourself that lead to new insights. In this podcast, we cover historical and current anthropology, comparative religion, and history. Welcome, and let's get started.
Hello, this is Richard Jacobs with the Good Question Podcast. My guest today is Gary Scheiner. We're going to talk about GLP-1 medications for type 1 and type 2 diabetes. People may know them as Ozempic or Mounjaro or tirzepatide. They're like exploding all over the place. Everyone seems to be injecting themselves with these substances. So a very important topic, I believe. Gary is the owner and clinical director of Integrated Diabetes Services. It's a multidisciplinary practice based in Philadelphia. It specializes in intensive insulin therapy and advanced education for children and adults worldwide. And Gary's up on all the latest diabetes management tools. So welcome, Gary. Thanks for coming.
Thanks for having me, Richard. This is a topic that's personal to me. I've lived with diabetes for over 40 years, and I've actually been using one of these GLP-1 medications for the past several years, and it has made quite a difference in my own life, as well as countless patients that I work with across the U.S. and across the globe.
And you would say it's near and dear to your heart. It's actually near and dear to your pancreas, I guess.
Yeah.
Make a bad joke. Yeah. Well, tell me, I hope it's not invasive to ask, but do you have type 1 or type 2?
I have type 1.
Oh, that's really difficult. Your body essentially produces almost no insulin, and you have to regulate everything, right?
Pretty much, yeah. I say you have to think like a pancreas in order to manage this disease properly.
Al, after all these years and all this study, what tells you that you're managing your diabetes really well? Like, how good are you at it and why?
It's not just about the glucose numbers. It's not just about the CGM data. It's a quality of life issue. There are people who spend inordinate amounts of time and energy trying to manage their diabetes. And even though they achieve pretty tight control, it's just not worth all the sacrifice. By finding you have to strike a healthy balance between the energy and effort and cost involved in managing it and what you're able to achieve from a blood sugar standpoint. And these GLP-1 medications are fairly unique in that they, in some ways lessen the amount of effort and workload the user has to put in while simultaneously improving glucose control. In a way that they're a lot like the automated or semi-automated insulin delivery systems that we have now as pump users in reducing the amount of work and generating better results.
What are the benefits of the GLP-1 and GIP inhibitors, for folks that have type 2 diabetes and type 1? What's the difference? The benefits of it.
I think it's important to take just a small step back and explain how these medications work. They have a multitude of effects in the body. And what they are doing is they're replacing hormones that the body produces that affect other parts of the body. We call these incretin hormones. They're normally produced by intestinal lining and other parts of the body, but people with diabetes don't produce these hormones in sufficient quantities. What these hormones do, first and foremost, is they act on the central nervous system to block appetite. They create a sense of satiety, so we're not hungry and not looking for food all the time. They also have an effect on the gastrointestinal system in slowing the movement of food through the stomach into the intestines. So food digests much more slowly than it normally would. It also has
does food digest more completely? Like, what is the condition of the food exiting the stomach with or without, these medications, like the subsequent, small and large intestine, the rest of the body? How does it process it differently?
It's an excellent question, Richard, because in people with diabetes, food digests faster than it's meant to. We lack a hormone called amylin, which is normally co-secreted by the beta cells of the pancreas. So people with type 1 and type 2 diabetes digest their food faster than it should be. And that not only causes spikes in the blood sugar right after eating, but creates this constant sense of hunger because the stomach doesn't remain full. It's almost always in an emptied state, and we're looking for more food. So in some ways, these medications, these GLP-1 medications, are evening the playing field a little bit and giving people with diabetes a fighting chance, not only to manage their glucose, but also to manage their food intake better. The older part of the body
One quick question here. So if someone with diabetes will tend to have fast stomach emptying, would the stomach then, and the stomach's empty a lot, would the stomach then start to produce less acid? And that could be mistaken as for other problems because the stomach doesn't need to put out as much acid for as long. So maybe it downregulates. I don't know.
It might, but it certainly creates a hunger sensation when the stomach has emptied. And that's a challenge. And whether you have type 1 or type 2 diabetes, managing your food intake is necessary. You can't graze when you have diabetes. And overeating obviously is going to lead to higher blood sugar levels than we want to see. And then we have to consider all the other health effects that people with diabetes have to face, the cardiovascular problems. And overeating and choosing the wrong kind of foods is going to work against that as well. But I don't want to ignore the impact that the GLP-1 medications also have on the pancreas itself. It does two things to the pancreas. One is that it promotes the release of insulin from the beta cells of the pancreas. So in people with type 2 who typically can still produce their own insulin, it enhances the insulin secretion. And it does it in a way that doesn't burn out the beta cells the way older medications like sulfonylureas used to do. This facilitates more easy release of insulin into the bloodstream. So the beta cells aren't worn out and broken down the way they are with the older medications. And it only does this when glucose levels are elevated. So the beta cells can function normally and produce insulin when it's needed. So for people with type 2, that can make a tremendous difference.
What is considered elevated by the body versus by science?
Elevated glucose?
Yes.
Well, anything above normal. You start seeing glucose levels above 100, you're going to start seeing a little bit of extra insulin secretion take place in an effort to keep the glucose levels at or below approximately 100 most of the time.
But is there a certain threshold where it'll release more glucose than it appears to need because it projects that, a lot more, like a large signal is coming?
Well, that's the thing. With the older medications that would just force the beta cells to squeeze out large amounts of insulin, regardless of the blood sugar level, they could cause hypoglycemia. And they also tend to cause weight gain because there's more insulin in circulation than is needed. These GLP-1s just make the beta cells more vibrant. When insulin is needed, they're able to secrete it more easily and readily. So the GLP-1 meds by themselves, they don't contribute to hypoglycemia or low blood sugar. And just the opposite, they tend to produce weight loss rather than weight gain.
So they produce weight loss, though. The food is more digested before it goes to the rest of the system, maybe theoretically putting less pressure on it.
Well, there's two reasons for the weight loss effect. The first is that people just tend to eat a lot less food. The hunger sensation is greatly diminished. People tend to fill up a lot faster than they're used to. There aren't the cravings to eat in between meals the way there is before the medication is used. So reduction in food and calorie intake is a big player in the weight loss. The other thing that contributes to the weight loss is that these GLP-1 medications block the production of another hormone called glucagon by the pancreas. Glucagon stimulates the body to secrete sugar into the bloodstream. With less glucagon, there's less sugar in the bloodstream, fewer calories present in the bloodstream, and less insulin required. So that also helps with weight loss.
Is there any way to tell anecdotally from people taking these drugs, how much is appetite suppressed? How much are things changed? How different do they feel and when?
A lot of it depends on the dose and type of medication that's being used. One of the medications called Mounjaro, the generic name is tirzepatide. Mounjaro has two medications that suppress appetite, GLP-1 and something called GIP. That seems to have a greater appetite suppression effect and lead to more weight loss than the others, but the others all contribute to weight loss to different extents. The dose a person takes is going to effectively determine how much weight they're going to lose. But there's a trade-off because when you get to very high doses of these medications, they can cause quite a bit of nausea, which is unpleasant. And again, thinking about a person's quality of life, sure, it's wonderful to lose a lot of weight, but if you're going to be nauseous all the time, is it really worth it? Some of the medications can be titrated in fine increments, so we can get to a dose that produces weight loss but doesn't cause excessive nausea. That's why, one of them called semaglutide, Ozempic is the brand name, is probably the most popular among people with type 1 diabetes, at least because the dose can be adjusted in very fine increments so that you can take the amount that's necessary to get the desired effect without overdoing it and producing a lot of nausea.
For type 1 diabetics, would it be dangerous for them to be on a significant amount of one of these weight loss drugs? Because if their appetite's suppressed and their insulin goes lower and lower and lower, because they're not checking it, I guess they can go into a hypoglycemic state.
Oh, you're absolutely right. And that's why anybody using these needs to work with a healthcare professional who knows what they're doing and knows how to adjust and fine-tune insulin levels in people who start using them. Now, my practice, Integrated Diabetes Services, is we specialize in working with people who are on intensive insulin therapy. So adding a medication like a GLP-1 is something we're very familiar with. We can help them make the appropriate adjustments. Often the adjustments come in the form of the basal or the long-acting insulin that a person requires. A lot of that has to do with the glucagon suppression, reducing basal insulin needs. But as people lose weight, their overall insulin needs, including the mealtime or bolus insulin doses, need to come down. And we teach everybody who's on rapid-acting mealtime insulin to match the dose to how much they're eating. So if they're eating less, they automatically would take less insulin. But you're right, if somebody's not taught how to do that or make that sort of adjustment on their own, it can be a problem. They will likely experience a lot of hypoglycemia. Some of it could be quite dangerous.
How do people react when they first start, one of these protocols? Like, what are some common reaction patterns?
Usually the word hallelujah comes up quite a bit. For the first time in a long time, these folks feel like they are back in control of their food intake. They're not driven by intense hunger to be eating all the time. It's one of the unfortunate things about having diabetes. Insulin stimulates hunger. And I mentioned before, the lack of the amylin hormone, which is present in almost everybody with diabetes, is a lack of this amylin hormone. That also contributes to excessive hunger because the food digests much too quickly. It's a very nice state for most people to go from just being driven to eat constantly to not being driven to eat. You eat when you feel like eating and not because you're ravenous constantly. But some people also, if they're not advised properly, they might be given too high a dose of a GLP-1 and might become very nauseous at the beginning. We recommend starting at very low doses that might have no effect whatsoever, but we can titrate the dose up slowly and carefully so that it's done safely, so that somebody's not going to experience excessive nausea when they begin using these.
So how do people know, I don't know, maybe it's a stupid question, but how do people know when to eat? Do they say, oh, wow, it's been like 6 hours, I better get some food? Or how do people deal with it?
Yeah, I think that's a key to getting the GLP-1 dose correct. We don't want to just knock out someone's appetite so they never want to eat. We want to get it to a point where it's just controllable. When a mealtime rolls around, yeah, you feel like eating. You've got some appetite. You still enjoy food. We don't want people getting to the point where they don't look forward to eating and don't enjoy their food. We just don't want it to be pressing on them all the time to be eating more and more.
Is there an average amount of weight loss, like percentage-wise or pound-wise, or, and how long is it? Is it really fast at first and then it slows down?
Most people lose a reasonable amount of weight the first few months they're on this. It's not unusual to see 10, 20, even 30 pounds of weight loss in the first several months, but it kind of tapers off and it levels off after a while, and people are sort of at a maintenance level from that point on. One of the unfortunate things about these meds is that when you stop taking them, the appetite does come back pretty strongly. There are some clinicians looking at reducing the doses slightly or using them intermittently to try to avoid sort of that whiplash effect of going from not very hungry to ravenous again. But most people who start using these stay on them permanent.
Oh, wow. So how long have people been on either Ozempic or tirzepatide? Some of them years now?
I've used it for about 4 years now. And we did use an amylin replacement hormone called Insulin years before that. And Insulin was not easy to use. It had to be injected before every meal, caused intense nausea, would often cause low blood sugars after meals. It was difficult to use. These GLP-1s are it's one flat dose you take typically once a week. It has more of an even effect. It's not the ebb and flow we used to see with Insulin, or even the early GLP-1s, which were taken twice daily, had an ebb and flow. You'd go through hours of the day where you didn't want to look at food. And then as it was wearing off, you're searching for everything and anything you can find to eat. The medications we have now, these once weeklies, they're very steady and stable throughout the course of the week for most people.
I guess you're one of the, GLP-1 grandfathers since you've been doing it for so long.
I guess you could call me that. There are people who have been on them longer than I have. I have a lot of experience using them with patients over the years. We work with a lot of type 1s in our practice, and it's a specialty that's kind of unique to our clinic. All of our clinicians live with type 1 personally, so we can lend that expertise. But one of the biggest challenges in using GLP-1s in type 1s is getting the medication approved by their insurance. Most health insurances will cover them for people who have type 2, especially those who are overweight or obese or who have other comorbidities, other heart disease risk factors. But if you just have type 1 diabetes, it's not easy to get it approved. You often have to be obese or have a serious weight issue before they'll even consider approving it.
Why do they make it so difficult? What are they worried about?
They're worried about I don't think they're worried. They're worried about their bottom line, is what I think. There's been plenty of research showing the safety and effectiveness. What we're lacking are the clinical trials. Now, there is a clinical trial going on now that Lilly is sponsoring in the type 1 diabetes space with their GLP-1s, but we haven't had anything else before this. And without wide-scale clinical trials, the FDA isn't about to approve a medication like this for a particular use. So we have to wait until those clinical trials are completed, and then it can be submitted to the FDA. And once it's approved, then insurance companies will more or less be forced to cover it for people who are qualified.
How is it in use if there weren't clinical trials for it?
It's often prescribed off-label. A physician can prescribe it if they feel it's going to be beneficial. So it can be prescribed to people with type 1. Their insurance will consider it and decide whether they're going to approve or not. Some people have gone the route of asking their physician to diagnose them with type 2 diabetes so that it will get approved, and that often works. Others will, if they're overweight, may be able to get it approved that way. But off-label use of GLP-1s it's fairly normal at this point. Most endocrinologists are comfortable and have been using it extensively with their type 1 patients. It works really well in the type 1 population.
Oh, I'm sure it works well. I'm just surprised. I thought a lot of drugs, they go through clinical trials and then they're used. I thought it was rare that first use is off-label and then clinical trials happen.
Yeah, it's what they're approved for is a specific audience, a specific market that they're tested on. So, for example, if the clinical trials had only included women, then the GLP-1s would only be available to women. They can't extrapolate and say that it's good for everybody. And these studies studied it in the use of treating type 2 diabetes specifically. So that is all it's indicated for. So the companies like Lilly and Novo and Sanofi are looking to get it approved for use in the type 1 population also.
Who is it not good for and why?
Well, I guess it's not good for people who have gastrointestinal problems to begin with. Perhaps they have gastroparesis. Now, in terms of side effects, there's a low incidence, but a reported incidence of pancreatitis and thyroid cancer. So people who have a history of thyroid cancer, have a family history, they wouldn't be good candidates for this.
Well, what if you had thyroid cancer and the guy get thyroid? Has anyone looked into that? Or
not that I'm aware of. It's possible, but
there's a lot of people on Synthroid, that or levothyroxine.
Oh yeah, but that's not thyroid cancer. That's a default.
It was taken out, right? But it could be for cancer, other reasons. But
yeah. The hype, like 30% of people with type 1 end up with another autoimmune condition like hypothyroidism. That's very common. But that's it's not a cancer situation.
You know, if there's a lot of study being done to look at people who have had thyroid cancer and if the thyroid's removed, you could participate, or it's not worth it? There's just so many people that can, they're not going to do it.
It's possible, but given the relative size of the market, these clinical trials are very costly. They go on for years typically, and they're very, very expensive to the drug companies. And granted, they're going to make a lot of money on it eventually, but often they don't want to invest that kind of money first to meet the needs of a small audience or what they perceive as a small audience.
So, since you're such a long-term and experienced user, do you experience it differently for people that, are only on it for 6 months, let's say?
I've had a good experience with it overall. It took time to get my dose of Ozempic at just the right level. And I had to keep raising the dose over a period of a few months and got to a dose I was comfortable with, and I went higher than that, and I really felt the nausea symptoms, so I backed off. That's often what happens is you keep pushing the dose up until the symptoms become unpleasant, and then you ease back to what you were comfortable with. That usually works out though.
Why do you have to keep raising the dose for so many people? Is it just not enough appetite suppression, or do they become accustomed to it?
That's exactly right. It's not exactly an on-off switch. It's more like a dimmer switch, but you still want to be able to see clearly. So you turn the dial as high as you can until it goes a little too far, and then you dial back a little bit.
Has there been any illicit use by people with eating disorders? Or is that not a worry?
Yes. Without a doubt, that has happened. And I think people without health conditions like diabetes or obesity have used it just to keep their weight down. And honestly, I can see why people would sometimes want to do that if they struggle to keep their weight down because they're driven by constant hunger. These medications can certainly help. It bothers me a little bit that the drug companies are reaping such huge profit on these medications. And we have such an obesity epidemic in this country that we could take such a chunk out of that epidemic with more widespread availability of these medications. But I'm hoping that they're using all their profits to develop drugs for other conditions and to help more people. But, greed being what it is, I'm guessing a lot of it is winding up in shareholder pockets.
Sure, no movie stars are ever contemplated using it either.
Never.
Well, so when someone finds out they have diabetes, how widespread is the knowledge of this use, GLP-1 and GIP inhibitors amongst, endocrinologists and people that help people with diabetes? Is this still new? How is the community welcoming it? Like, how are physicians talking about it?
Yeah, most physicians at this point are pretty familiar with it. The companies have invested a fortune in educating and preparing clinicians to roll these medications out. I'll tell you something interesting. I go to the American Diabetes Association's scientific meetings every year, and normally in the exhibit hall, there are some rather large displays and exhibits regarding insulin. The companies, Sanofi, Lilly, Novo, they're always there. There's always lots of info about insulin. The last 2, maybe 3 years, they have had absolutely no information available about insulin. And you would think that is the most commonly associated medication in diabetes care. They don't even touch on them anymore. I think there's almost hardly any research going on in insulin use these days. Those companies are pouring all of their resources into GLP-1s and weight loss medications.
Well, it makes sense. So, we're just about out of time. I guess the best way for anyone with diabetes that's not, their physician hasn't spoken to them about it, they can bring it up with their physician. How do people learn more about whether they are a good candidate to take one of these drugs?
And there's a lot of information online. Some of it's trustworthy. A lot of it is not. So it really is best to work with your physician, whether it's your primary care physician or your endocrinologist, to find out if a GLP-1 medication is in your best interest. Obviously, there are pros and cons. There's drawbacks. There are side effects associated with these, and your physician will be able to guide you best. Folks to reach out to my practice if they want. They can go online to integrateddiabetes.com and see what we're about and contact us by phone or email.
And you can help people in the Philadelphia area and some radius there.
We provide mostly virtual care. So we have patients on every continent and every state in the U.S.
That's great. Okay. Well, very good, Gary. Thank you so much for coming on the podcast
You got it, Richard.
I appreciate it.
If you like this podcast, Please click the link in the description to subscribe and review us on iTunes.
Thank you for listening to the Good Question Podcast. Please email support@thegoodquestionpodcast.com if you have any referrals to great guests for us to interview. Visit thegoodquestionpodcast.com to hear more interviews. And please help us spread the word by rating and reviewing us on Apple Podcasts, iTunes, Spotify, YouTube, or wherever you listen to this podcast.